Hey everybody, welcome back to Symmetrically Fit. I'm Dustin Gotro. We've got Katy Girlinghouse and Dylan Stone with us today. We're going to do things a little bit different today. So, a big reason I wanted to bring three different specialty areas into this podcast is we want to learn as well as you guys. So, as we run into specific topics, we'll bring in that person to kind of take over the podcast for that day, and we're all going to kind of learn together. So Dylan and I will kind of sit back. I'm going to sit here and drink my coffee, and we're going to learn from Katy. So, real quick before I forget, guys, go to Facebook's Symmetry Personal Training, follow and share. YouTube, Symmetry Personal Training, subscribe and share to keep up with these video podcasts. All right, I'm going to turn things over to Katy. What are we talking about today?
So last time we had some questions about incontinence, and so we thought we'd jump into that and talk about when it's appropriate, when it happens, when it's common situations where it might come up, and how we deal with it. So first thing I want to touch on was different types of urinary incontinence. There's two main types. It could be urge incontinence, and that is the gotta go, rushing to the bathroom, feel like you're gonna leak or you do leak on the way there. And then we have stress incontinence, which is I think what we're going to focus on a little bit more today. And this is the jumping, coughing, sneezing, lifting weights type of leaking. So I want to start with just like, what is the pelvic floor? Because a lot of people don't even know that. So I got my little handy model here. So we have our pelvis. We have pubic bone in the front, tailbone in the back. That's our coccyx. And then our ischial tuberosities. And that's the part that we sit on. So pelvis is sitting up like this. All of these muscles between those bones is the pelvic floor. You can break it up into different layers. We often treat it as one muscle group because they work simultaneously together. But there are ways to break it apart if we need to. Really, that group of muscles' job is to hold back pee, hold back bowel movements, and then relax fully so that you can empty your bladder, empty bowel, have sexual intercourse, and then it needs to be strong to work with the rest of the core to give you stability with your movement. Okay. So Dylan wanted to touch on the different types of muscles and how they're connected into in the body. So Dylan, you want to jump into that?
Sure, absolutely. So I'll start with saying I'm not a pelvic floor specialist. And so I was thinking coming into this podcast, how can I contribute just a little bit and then sit back and let the expert do her thing? So here's what I got in terms of kinesiology or how the body moves. So what makes pelvic floor really interesting, let me back up here a second. So we have three different types of muscles, I guess, depending on how you categorize things. So the most common type is muscles that connect bone to bone. So think of any muscle, biceps, triceps, levator, scapula, anything. It's connecting two bones, two or more bones, and it's pulling them together. The next one is what connects bone to tissue. The most common example is any muscles in the face. There's muscles that connect your facial bone to your mouth so that you can smile, frown, make noises, all that stuff. And then the third really cool and most rare type is muscles that connect tissue to tissue. And the most common examples that you can think of are probably the urinary sphincter or the colonic sphincter. Yep, there you go. Katie's got the example. So anything with the name sphincter in it is probably connecting tissue to tissue. And some really cool, well, from a kinesiology perspective, some really cool things happen when you talk about muscles that connect tissue to tissue. So the coolest thing that I remember is that you can, biceps, if you're safe with it, you can't overtrain biceps unless you go too hard, too fast. But Katie, correct me if I'm wrong, you can overtrain a sphincter, right? And so you can go from having urinary incontinence where it's not trained enough to having urinary retention or you can't pee, right? Is that correct, Katie?
Yes.
Yeah. So I thought that was really interesting, but okay, now I'm here to listen.
Okay. So what, just off the bat, what questions do y'all have about pelvic health or incontinence?
So I'll kind of lead in with the question I had last time on our pilot is so something I hear a lot with my patients, again, pediatric physical therapist, so my patients are the babies, and then I also see the postpartum mothers, and I ask them questions while I'm treating their child. And something I hear a lot is that, oh, I just had a baby, so I pee when I sneeze, or I pee when I lift up my child. It's just normal because that's the thing. And then the other thing I've also heard is, oh, my mom had incontinence and my grandmother had incontinence, so it's just genetic. So, Katie, here's the softball for you. Is that normal to have urinary incontinence?
No, it is never normal. So it's I will say it is really, really common postpartum, but it is never normal. And I don't care if it's 3 days postpartum or 3 years, right? It really, you should not have leaking. If it's 3 days, you sneeze once, you leak, and then you sneeze the next week and you never have any leaking again, I'm not going to worry about that because your pelvic floor has recovered from birth. But if it's happening, it's getting worse, or it's staying the same, then that's something that needs to be addressed, to work on. And then as far as the genetic component, um, we don't have like a strong connection of, if your mom has incontinence, then you will have incontinence. But we know that body types and tissues are genetically connected. So if your parent tends to be a little more hypermobile and have a lower muscle tension, then you probably will too. And those things are going to lead to leaking.
Oh, very interesting. I didn't think there was any genetic component, but it's very interesting to hear that there's at least some, right?
Yeah. So we hear a lot about like prolapse, what, like my mom had it, my grandma had it, da da da. And I'm like, well, everybody's birth is different, everybody's
Mhm.
life is different, but there may be some pieces. It's one factor in a lot.
Okay, very cool.
Do you know if
Yeah.
there may not even be any research on this? I'm also not a pelvic expert at all. Um, but do you know if there's any research that you're aware of that shows whether that's because of the way that they are built because of genetics? For instance, how their pelvis is structured, or is it something that just because they have the same DNA, it ends up happening to them?
As far as like the shape of the pelvis,
Yeah, like how much of it is related to that, as far as losing control of those muscles?
yeah. So as far as I know, there's not any research on that, but I, I see all different body types with leaking. So just clinically, I would say there's not a component as far as like bone structure, body shape, style, that piece, but
Mm.
more so as how much muscle tone they have, how much they work out. Because even though it's not genetically, you do what your parents do, right? If you
Mm.
see your parents working out all the time, if they were active, then you're probably more active. And so it's more the muscular system and how well you're able to coordinate and what your strength looks like.
Okay.
Very interesting.
Katie, I did have a question for you. So we're talking a lot about postpartum and stress incontinence. Um, so you think about that, and then on the other side of the spectrum is people who lift a lot of weight, right? And I think we've all seen that video or multiple videos of people lifting weight and urinating at the same time. So
Mhm.
what is kind of the differences and the similarities between a woman who is 3 days post birth doing that, and then a woman who is lifting 600 pounds and doing that?
Yeah, so I would say similarities. Obviously, they're both leaking. So there's some
Mhm.
pelvic floor dysfunction happening. They might look totally different. The mom who just gave birth may have more pelvic floor weakness, or they could have tension, or there could be other pieces. This is it's not always like one problem. The woman who is leaking, or the man, right? Because men
Mhm.
could have leaking too. But typically for lifting, it's going to be women leaking. With that, I'm more looking at pressure management. They're probably strong if they're lifting that much. That's probably not the problem. it's that they're not managing their pressure really well. And so for that, we look at whole abdominal canister, what's happening with rib cage, what's happening with diaphragm, what does their breathing look like, what is their abdominal strength, back strength and mobility, and then hip strength and mobility. So we might look at all of that canister with the mom early postpartum, but there may be, it's going to be less of a factor or a different factor than the lifter.
Okay, gotcha. And you kind of touched on this already. So men can have stress incontinence, right?
Yes. Yeah. So men can have stress incontinence. I would say for men, stress incontinence usually comes after a prostatectomy or a prostate cancer and surgery. And so with that, part of the prostate's job, part of it is controlling that urination. And so because it goes around the urethra. And so when you take that out or you reduce the size of it, there's not as much pressure on the urethra and you lose a little bit of control. So that's more often we see it. Like I don't see it with lifters that often. I don't see it with younger men often. It's usually after a prostate surgery.
Gotcha. Okay. Yeah.
I've got
one sentiment. Go ahead, Dustin. Yeah.
So with men, I'm curious as to where this falls in, if it's the same thing or something similar, or if you're even aware of this. So with men, usually when they get older, there's this issue of after they go to the bathroom, what I always hear termed as dribbling. Where does that fall into what we're talking about here?
Yeah, so that we call it post-void dribbling. So after you pee, you leak. We had a fancy name for everything. So with that, let me grab my male model. This will.
Katie's our friend with pelvic floors all over her house.
I do. My kids know all of the parts of the pelvis, and they can take them apart and put them back together. So we got our pelvis model. So if we look at the pelvic floor for male genitalia, we've still got all of these muscles of the pelvic floor. We still got the sphincter, but the pelvic floor creates the base of the penis. So this muscle here, its job is to help support an erection, but with urination, that muscle should help push out any urine, and then it should relax. So when you go to pee, it should help push everything out. But if it's not strong enough, then you're not going to push everything out, and you'll get a little bit of dribbling afterwards.
So very similar issues. What do things look like on the end of? Is that kind of the same type of fix to what we're talking about, or is it an entirely different kind of situation?
Yeah, so with everyone, I look at what does pelvic floor strength look like? Do they get a good coordinated contraction with the whole pelvic floor squeezing and lifting up? And then can they relax fully? So that's the first thing I got to know. If they're getting a good contraction, but they're not relaxing all the way, then we've got to get that mobility back so they have good full lengthening. Sometimes it's just as simple as get that range of motion, and then all of a sudden you can contract better because you have the room to get that contraction. And then it's all the same things. I still look at pressure management. I look at whole body, like core strength throughout the whole system, diaphragm, rib cage, abdominals, and back. But did I answer your question? I got sidetracked there in my brain.
No, I just wanted to throw that in there so guys out there, that's not normal either. that is also
another thing. Yeah, super super common, but it is not normal, and I would say it's more normal in your like 70s, 80s, and on. But if you're in your 20s, 30s, 40s, even 50s, then I would say that like you shouldn't be having that.
And one, this may just be a funny sentiment that I've heard. So when I did work with adults, I heard when people who were in for like pelvic floor rehab and whatnot, they would say things like, "Oh, I've been having symptoms for years," and the only reason they went to go get treatment is because it started affecting sexual function. And I'm like, is there a more guy trope than that? Is like, you're fine with all these symptoms, and like these symptoms are not normal, right, Katie? They're not normal, but the guys wait until it starts affecting sexual function, and then they're like, oh, I should go get that treated.
Right. Yeah. That is what I see all the time in my clinic too, that it's like, oh, if I dribble a little bit after I pee, like ultimately that doesn't make that much of a difference in your life, right? It doesn't harm anything. It takes 3 more seconds. Like it doesn't change your life. But when it starts to become pain when you're sitting at the office, or pain while you work out, or you're having sexual dysfunction, then yeah, it becomes a real problem. And that's when men reach out. Women tend to reach out much earlier because they're like, this is not right. I know my body and this isn't right.
I feel like a little,
so for
people
our
are just
male,
embarrassed. People
Yeah.
just don't want to talk about it. That's why I like that we're talking about it, because I want to get this out there. I want people to see that this is fixable. You don't just have to live with it and be too embarrassed to talk about it. There are people like Katy out there that can teach you how to fix this and get it back to normal. So I think this is really cool, even though it's always an awkward conversation.
Yeah, and I say I do it enough that it's not so awkward for me, but I am very aware that people coming in are like, I have to talk to you about sex, like my sex life with my wife, or my, with my partner. And I try to keep it, very neutral, be sensitive of that. And we stay, on the science, and let's talk about, what's happening with the muscles. What are you feeling? When is there pain? Because it is sensitive. And then the next piece people always say is, and like, how are you going to treat this? Because one, they've either told doctors and then been told there's nothing they can do about it. It's normal, deal with it. Or it's like, they've never heard of this. They've never heard of pelvic floor therapy. And so they don't know that there's ways to treat it.
And so for our male listeners out there who we know they reach out later, right, when things become more serious, what are some of the less serious times in which you think it would be appropriate for males to reach out to a physical therapist and see like, hey, is there anything I can do to optimize my function,
Yeah. So obviously the post-void dribbling is one. If you feel like you go to the bathroom and you have to wait a long time for the flow to start, then that's a sign that there's too much tension in the pelvic floor. And that's what you're talking about, that urinary retention. So you're not able to empty your bladder all the way. If you get diagnosed with prostatitis and you have no there's no like culture, but they don't know what else it is, there's no bacteria, you don't respond to antibiotics, then that is usually a pelvic floor is involved there. And if you have any constipation.
Interesting.
Yeah, that happens a lot, that people say, well, I've had constipation for like 15 years. And then it's just become other problems. And once we resolve that, everything clears up.
Okay. I would not think the prostatitis one, so that's good to know. Next time I get prostatitis, I'm going to come to you, Katy. So.
All right. We'll get it better.
All right. Oh boy.
So with all of that said, what is the course of action? Kind of give people an idea of how you go about dealing with this.
Yeah, so I look at a whole body, because the pelvic floor doesn't operate in a vacuum. There's a whole bunch of things attached around it. If we pull that pelvis back out, I mean, that's just one group of muscles in our pelvis. We've got the hips coming out here. So we've got a whole bunch of muscles. We've got adductors, we've got the abdominal muscles, and all of that needs to work together for the pelvic floor to do its job. So I look whole body, what is happening when you bend over? What's happening when you lift? What's happening when you squat? What are all your daily movements look like? And then in my mind, I'm thinking, okay, this isn't moving the right way. So how could that be affecting the pelvic floor? And we address those pieces that are dysfunctional to get them moving better, whether it's range of motion, joint mobility, muscle coordination. And then we look at pelvic floor specifically. Like I said, I want to know, is the muscle too tight and not able to relax? Or is the muscle weak and not able to get a good strong contraction? And it could be either one. A lot of things like stress incontinence, I see a lot of tension usually, but there's an underlying weakness. So they're just holding tension all the time to prevent leaking. But at some point, you can't hold anymore. And so you still leak. So we got to get that pelvic floor moving, relaxing, and build up strength. So do you want to know how I do an exam?
Oh, I do. I want to.
It sounds fun. Let's hear it.
Yeah. So I'll do vaginal, female first. So if we've got our pelvis here, I have the undressed waist down. And then I look at the vulva and what's happening there. I will push on pubic bone because I want to make sure these bones are not irritated and there's no joint dysfunction there. And then I'll look at these muscles here. So I've just put a little pressure on these muscles and see, is anything tender? Is anything not moving well? And I'll check the other side. And then I have them squeeze like they're trying to hold back pee and relax. And then bear down like you're trying to push out a bowel movement or start the flow of urine. With that, I should see a good nice squeeze and lift of the pelvic floor. This perineum between the vaginal opening and anal opening should lift up. And then when you bear down, it should come down towards your feet. So I'm looking for all of that movement. Then once I've done all that, then I insert a finger vaginally and I'm checking the deeper layer of pelvic floor muscles. And I see, can they squeeze? What does the strength look like? Can they hold it for endurance? And then how quick can they get that contraction? Because that's going to be important with a lift or a jumping and sneezing. We want quick muscle firing. The other really cool thing is I can actually get to the deep hip rotators internally. So I can work on those hip rotators that often cause a lot of pain with running or even with sitting or standing. It's a big trigger for a lot of people. So I can work on those internally. So that would be my exam for someone with vagina. And then if I do an exam for male, I have them use a sheet and tuck scrotum and penis up. So all I see is pelvic floor here. Right. So then I'm going to go through the same thing. What are these muscles doing? Can they contract? Can they relax? Any pain, anything not moving well? I didn't mention this before, but I'm also going to check nervous system. So sensitivity, any pain to light touch. The pudendal nerve runs right along this inner ischial tuberosity. So I'm going to check there to see if there's any irritation there, if I think that might be a factor. And then for internal, for men, I do check rectally. So I insert one finger rectally and I'm doing the same thing. I'm checking that deep pelvic floor. Can they squeeze? Can they relax? What's the endurance? What's that coordination look like? Mm-hmm. And usually about this point, I get the look of like, oh, okay.
How many people change their mind at that point? It's gotta happen.
You know, you would think it would be a lot. I've probably had one or two men who have ever said, I don't want to do that. And I said, okay, like by no means. And am I going to make you have a rectal exam? Like that is not okay. So, and women too. I've had a couple of women that go, I don't want to do an exam. Like that's okay. So then I said, are you comfortable with just the external, the outside piece? And if they are, we do that. If they're not, then I'm looking at the whole body and I'm making an educated guess on what's happening with the pelvic floor based on their symptoms and based on the rest of the body's movement. So, and a lot of times I can get them much better with just that. And then sometimes I really do need to do the assessment to get that last piece or figure out what else is happening.
All right, Dustin, don't lie. Did you squeeze your pelvic floor when Katy was talking about it? I did.
So
I squeezed my pelvic floor.
I did, and that brings up a question. Katy actually mentioned this to me before. So in this situation, Kegels, good or bad for this? Helpful at all?
If the problem is weakness, Kegels can be helpful to work on that isolated muscle strengthening, just like you would strengthen anything else. If you want a stronger serratus, you work on serratus strengthening. If you want a stronger bicep, you can do bicep curls. We want to take it into a whole body movement because that's more functional. So then I might bring that Kegel into a squat, or I might add lunges, or I might do something else to get the whole body involved. But they can be helpful if truly pelvic floor weakness is the problem. If they have tension, then no, I'm not giving any pelvic floor strengthening. I want them to relax and lengthen. We might do some, well, let me tell you, I want them to relax and lengthen. Then once they have good range of motion and control coordination, then I'm going to go back and add that pelvic floor contraction, that Kegel in, because you need to be able to do it for life, right? If you push open a door, you pick up something heavy, you squat, your pelvic floor kicks on. So you need to have the ability to do a Kegel, but you shouldn't be stuck in a Kegel.
Well, so this exam, I was just thinking about, from my PT mind, any sort of contraindications for this exam, or, reasons to not see a patient. So the two populations that come to mind that could possibly be contraindications, asking you, Katy, are like third trimester pregnancy or like an active untreated hernia. Can you see those types of patients, or are you going to send them off?
Yeah, I would actually do exams on both of those patients.
Oh, okay, awesome.
Yeah. So the third trimester, we're really not worried about anything. I am not going to go poke on the cervix and mess with that. So if they were having cervical pain, then I would probably be more reserved in what I'm going to do internally. Or I would call their doctor and say, hey, like, what's going on here? Is this something we're concerned about? If they were on complete bed rest and their doctor said no sex, then I would not be doing an exam.
Mm-hmm. Okay.
Yeah. But if somebody's having sex, like anything I do is going to be way less aggressive than what they're doing anyway.
Okay.
There are typically we may not do an exam in the first trimester, and there's really no reason for that other than there's just a higher rate of miscarriage in first trimester, and so we don't want to increase that risk in any way. But there's no research on it. We're just afraid to do it.
Okay.
It's one of those things. So I just talk to my patients and, take it case by case and see, like, is this an appropriate time where I really need to do an exam? Can I get by without it for a little bit? And then maybe we do an exam in second trimester.
Okay. And untreated hernia, you can move forward.
Mm-hmm.
Cool. Okay. Awesome.
Yeah. Yeah. I would say if someone has like an active infection, like an active UTI, we're probably not going to do an exam either unless they're on antibiotics.
Okay.
Yeah. But everything else, we do it.
Yeah.
So, go ahead.
So I did want to ask about, because, like you said, pelvic floor does not happen in a vacuum. So what effect does like the inspiration and expiration, or the inhale and exhale portion of breathing, have to the pelvic floor?
Yeah. So our pelvic floor, if we think of it, sits here, and then our diaphragm sits up on top at the bottom of the rib cage. So when we inhale, the diaphragm contracts down. And if the pelvic floor doesn't move, that increases the pressure in the abdomen, right? That pressure has to go somewhere. If the pelvic floor is not moving, that pressure is going to push forward or backwards. So that's if someone has a disc herniation and you get increased abdominal pressure, that's why that could increase that pain. But what we would like to see is that this diaphragm comes down, pelvic floor comes down, and the amount of pressure stays the same and it's balanced out. So we inhale and pelvic floor relaxes. We exhale and everything squeezes. Listen up.
I'm breathing along with you. I'm trying to do it on myself so I understand what's going on.
I think that point is huge. The breathing. And just from personal experience, I'll say this: Katy worked on my rib cage and kind of busted things loose, which I was very sore in my rib cage for several days after. But as a trainer and all of my clients, you already know this. I'm really big on the draw in maneuver to activate the core. I'm a firm believer in trying to do it all the time, all day long. And once she worked on my rib cage, taught me how to breathe properly, that draw in got so much easier. I never realized how much I was fighting that pressure in the stomach that you're talking about, Katy. That was just, it was like locking my rib cage up. I wasn't able to breathe. And so I think breathing's something people just kind of don't think about when we have these kind of issues, and it's really a big part of it. Um, so, Katy, with women that go through their pregnancy, how soon after pregnancy should they seek help if they're having this issue?
So as soon as you realize there's an issue, I typically, with my clients that I see prenatally, I start them back 2 weeks postpartum, which feels really early, and nobody's moving much at that point. But it's much easier to address movement dysfunctions, get the breathing, the rib cage moving, because there's so many changes in pregnancy where the rib cage expands, and then it's kind of stuck in that exhalation, inhalation. And then you've already got diastasis. And so we want to make sure all of that is coordinated and everything is moving really well. So I start that 2 weeks postpartum, and then I see them every couple of weeks. We just check in and we progress things back to where they want to be. I would say it's at any point, if you feel like something is not right, that you're leaking, that you're having pain with bowel movements, that something just doesn't feel right, then reach out to a pelvic health therapist, because they can address those things, even if you think, or even if you've been told, well, that's normal, it's just postpartum, give it a year. It's probably not going to just go away, because you've created movement patterns during pregnancy, and those patterns are going to stay until they're changed. Yeah.
Perfect. That's what I was kind of getting at.
How about women who have a C-section? Is there a certain amount of time they should wait? I'm guessing, do they need physician approval before they start physical therapy?
No, actually, we start that 2 weeks. I mean, scar tissue healing time for the skin is 10 days. So we usually wait a little bit longer than that. We give it 2 weeks. We make sure there's no open points before we start scar mobilization. But beyond that, everything else I do is the same. I make sure rib cage is moving, that they have a good coordinated abdominal contraction, that pelvic floor and abdominals are working together. And then we look at postural things, and we make sure that if they're nursing or just holding their baby, what does that look like for them? Because I see a lot of moms with that rounded back, they're reaching down for their baby, they get forward shoulders, they've got forward head, and then they end up with neck pain 12 weeks later because they've been sitting like that. And if I can catch it early and we can modify some of their daily activities, they never have to go through that pain.
Mm-hmm. You're getting into my realm too, because when I'm at home with the mother, I'm like, okay, how do you breastfeed? Or are you breastfeeding your bottle, and then are your shoulders up? Yes, I see that as well. So can confirm.
Yeah. Yeah, but it's and I educate lactation consultants on it too, because we're all anyone who sees the mom should be recognizing these things and giving them a little bit of education and resource. And just if we're all constantly reaffirming that, hey, these things are important, then sometimes it'll click, right? I mean, they say mom brain's not real, but it is real. Nothing functions. You don't know what's happening. You're going to hear the same thing 15 times. It goes in one ear and out the other. And then the 16th time, you're like, oh, I'll try that. And then it feels better. And sometimes that's just what it takes. So if all of us are on the same page and helping moms be aware of that, it makes such a difference.
Okay. Well, I have all my questions answered. I'm sure I'm going to have 18 more by the time we hang up, but
You know how to find me.
Yeah.
Well, Katy, did you have any more you wanted to cover?
No, I think that's it. I mean, I would say one more thing. The biggest thing that I want to encourage people is if something feels wrong with your body, or if you think like this is not right, this is not how it used to be, but I've been told by any number of providers that it's normal, get another opinion. And physical therapist, I mean, I know Dustin, like you're definitely on this page too. It's like if it doesn't feel right, like let's figure it out. Let's look at it. Just don't settle for it's just going to be that way.
Great advice. I like that.
Well, Katy, I thank you for talking about all of this. It's not a topic I would have ever felt comfortable in my knowledge to discuss. So I'm glad you were. I learned a lot. I think a lot of people out there did. And I'm really glad this topic came up because in my industry as a trainer, this issue actually comes up a lot. I don't know why it is, but clients tell their trainers everything. Sometimes you'll tell me more than I really want to know. But it really does. This issue has come up a lot. I mean, I've been hearing stuff about this since we did CrossFit 15 years ago. This happening when people did box jumps or sprinting, just all kinds of stuff. So, and quite honestly, up until the last few months that we've been talking about it, I kind of was on the side of just thinking, well, this is just something, it's normal for this to happen to women after they have kids, and seeing how it relates to similar issues that men have, I think is really interesting. And I definitely urge anybody that has any of these kind of problems, reach out to Katy and see about figuring it out. And it'd be nice to not have that issue if you're struggling with it. So, Katy, if someone is having this issue and they call your clinic, what do they say? What's the right way to, I guess, seek help for this?
Yeah. So if you just call and you say like, I mean, you can be as open as you want or not. All of our team is very aware of what's happening. Even our receptionists that answer the phone have gone through pelvic health PT. They know what the experience is like. They're happy to answer questions. They're sensitive to the fact that these are hard topics to talk about and they can be embarrassing. And sometimes you don't even know what the problem is. And you don't even have to tell them anything. You can say, I just want to talk to the PT. We do a consult call where the PT will spend 15 minutes with you on a video call and answer your questions and make sure that you feel heard and any concerns that you have before we even come into the office and do an exam. So you don't even have to say anything. You can just say, hey, I'm this might be the right thing for me. I want to talk to a PT.
Awesome. And what's the best way for people to contact you? And I'll put this in the description as well for you guys.
Yeah, so you can reach our clinic and me at 214-600-8168. You can call or text that number and somebody will get back with you. And then you could also email me, Katy, Katy, at thefitpelvis.com. And that'll go straight to me so I can answer any questions. And if you don't live near me, you don't want to work with me, I'm happy to recommend other places and help you find someone who can help you.
Awesome. Well, I think that does it for this episode. Thank you guys for joining us. We'll leave all the info in the description. Stay tuned for next week. I think we're going to get into the topic of rolling the IT ban. So if you are rolling the IT ban, stop until we talk about it next week, and we'll get to all the details about it and why that might not be the best idea for you. All right. Thank you guys for joining. We'll see y'all next week.
Thank you.